All right, so I have a kind of a unique personal story that I've been sharing recently in my presentations, and I call it bridging the canyon, bridging a canyon, plant-based nutrition in the medical establishment. And I want to share with you today a little bit about this, what I call a canyon between what we know about plant-based nutrition and traditional medical practice. I'm sure many of you have experienced this in different ways. This is a picture of the canyon. That's an analogy throughout this presentation. So my personal story started back in around 2001. I was in this city, and I'm sure many of you know where this is. It's Miami. No, I'm just joking. It's San Diego. No, I'm just joking. It's actually Chicago. It's Chicago, and I was actually working there as an actor, pursuing a professional acting career, which meant that I was an assistant paralegal at a law firm. And I got a call there after being there and working for a little while. I got a call there from these people, my parents. That's T. Colin Campbell, my mom, Karen Campbell. And they asked if I wanted to help write a book about nutrition based on my dad's lifetime of work in diet and cancer research and diet research in general. And I thought it sounded like a great idea, so I decided to, a special opportunity, I guess you could say, very special opportunity. So I decided to go ahead and take a break from what I was doing and move back to Ithaca, New York. So here in our analogy, I enter on this plateau over here on this side of the canyon. And this is Ithaca, New York. For any of you who know Ithaca, New York, it's a lovely town full of gorges and a lake and the Finger Lakes. So I'll make it a little bit greener there here in Ithaca, New York. And I started working with my dad on a book that was going to be called The China Study. And that took actually 4 years of work. And through that amount of time, I got much more involved than I originally had planned to do. I read looked at thousands of different scientific papers and abstracts, and I spent a lot of time in the library stacks. I did more than just editing. I got my hands into the writing, significant parts of it and so forth. And I got really passionate about the information. We spent a lot of time discussing science, discussing information, and it was a sort of a very special 4-year apprenticeship in literature review with a very accomplished nutritional biochemist and researcher. And at the end of that process, I had learned a few things, learned a bit of science about nutrition and its effects on health and disease. And this is not a presentation to justify a plant-based diet, but just to highlight some of the power of nutrition very quickly. Let me just mention a few facts about heart disease. I learned through those 4 years working on the China study that in many places around the world, heart disease is really quite rare. And if you look, for example, at traditional Chinese diets in rural China, back when my dad did the China study, and they used mortality data from the 1970s, there were 2 counties that had no premature deaths from coronary artery disease from 1973 to 1975. No premature deaths from coronary artery disease before age 65, what that means. Now that's remarkable. And so if you were in this country, in the US, and there was a county with that kind of fact, you might think, well, it's got to be a county in Nebraska that has, one family of 6 people, and none of them, they just got lucky, So in rural China, with no premature deaths in these counties, one county with no premature male deaths, another county with no premature female deaths. How big do you think these counties are in the 1970s? How many people can possibly live in these heart disease-free counties? And it turns out that when you look at the numbers, they're not so small. In one county, 246,000 people with not one single male death from coronary heart disease. Another county, 181,000 people, not one single premature death among women from coronary heart disease. So just think of it's mind-boggling, and I think a lot of people don't appreciate that or realize that. It's absolutely mind-boggling. And furthermore, you look around the world, there are places that don't have heart disease. When you look at intervention research, of course, skipping many decades of research and evidence, but you look at intervention work. This is, of course, a landmark lifestyle heart trial from Dr. Dean Ornish, who's a speaker at this summit. He showed in the Journal of the American Medical Association back in the 90s, 5-year data that really should have changed medicine. It has changed medicine, I should say, fundamentally. And that is looking at people with established heart disease. What you're seeing on this graph, on this axis, is that this is the average size of blockage in their heart arteries. On this axis, this is the diameter stenosis, the amount of the artery that's blocked. And on average, these people with heart disease started out at about 40% blockage of their arteries. And then one group, he had a whole food plant-based diet, exercise, group support, meditation. The other group got standard care. Now, this was at a time before statins were widely available and widely used. So these people were not on statins. Some were on aspirin, but no statins. And after 1 year, the people in the experimental group, what you're looking at is the line going down, showed shrinkage. The average size of their blockages in their arteries actually went down. Their artery blockages were shrinking. The standard care group got worse. This alone is remarkable, sort of revolutionary finding. I followed these people out for 5 years, and the evidence just became more stark that diet and lifestyle alone could continue to reverse heart disease, particularly the more compliant people were, and the standard care people continue to get worse, which is unfortunately what we expect people to do in our medical system. So this is remarkable. Of course, you're also familiar with Dr. Esselstyn, and this image of one of his colleagues with a very bad stenosis or blockage in his left anterior descending artery, and going on a whole food plant-based diet. Within 2.5 years, a repeat image, and many people are familiar with this slide, but showing that a whole food plant-based diet alone, just a dramatic image, a dramatic reversal, and cholesterol dropping, LDL cholesterol dropping, and so forth. So heart disease has a very broad and deep body of literature, body of evidence that supports a plant-based diet for prevention and treatment of ischemic heart disease, of atherosclerosis, another word you may have heard. And that's very powerful. I mean, you could just stop there. It's our number one killer. Stop there and be very enthusiastic for a plant-based diet, but it doesn't end there. And so when I worked on the China study, and I'm going to skip this. This is Dr. Esselstyn's long-term data showing from almost 200 patients that there were patients on the experimental diet on a very strict diet. This was a diet with no oil, no animal foods at all, and little to no sugar recommended, and added sugar, I should say. And there were people in the experimental group that had further events. Many of these events were not related to progression of disease. When you really sort of parse out these numbers, you see that one person out of 177, one person had a heart attack or stroke that was thought to be related to progression of disease, which is absolutely dramatically less than standard care that we give people. So long-term data from a couple different people suggests this disease can be stopped. When I was working with my dad on the China study, of course, I learned much more than just about heart disease. Much of his research was on diet and cancer. And again, I don't want to try to convince people about diet and cancer in this presentation, but just to highlight some interesting relationships that actually many people are not aware of if you're walking around on the street. I'm sure the audience here is quite savvy, but just realize that many Western cancers are Western. They're a product of Western civilization. They are not common in many traditional countries around the world historically. This is a graph showing breast cancer relationship to meat intake. And you can see here, there's this wide range. Some of the Asian countries have very low breast cancer incidence, and you have US, Europe, some other countries with very high incidence. And what's linked to it? It turns out that this is a very striking correlation, striking linkage between the higher the meat consumption, the more meat consumption in a country, the higher the breast cancer incidence. And this is, for those people unfamiliar with correlations, this is actually a very strong correlation. It's similar in strength to what you'd find, for example, between cigarette smoking and lung cancer. It's a very strong correlation. So this is breast cancer and meat consumption. This is colon cancer, another Western cancer, very low traditionally in many parts of the world. Colon cancer and meat consumption, again, very strong correlation. This is kidney cancer and animal protein consumption. This is prostate cancer and non-fat milk consumption. These are different countries around the world. This is testicular cancer and cheese consumption. This is ovarian cancer and milk consumption, uterine cancer, endometrial cancer, and milk consumption, and finally breast cancer and milk consumption. So realize we've known for a long time that many of our Western cancers are not historically the disastrous sort of behemoths that they've become in Western society, but also that they've also classically and strongly been linked to Western diets and lifestyles. It's not just these nutrients or foods, it's other factors of Western diet and lifestyle as well. And of course, through the course of the China study, I learned so much more about diet and cancer and experimental data and my dad's research and his work in great depth. And it became, between heart disease and cancer are number one and number two killers. This is very profound information. Most people, when you really get down into it and you start learning about it, it's hard not to walk away a bit flabbergasted and sort of impassioned by the power that people don't even know about, their breakfast, lunch, and dinner choices. So it's not just about diet and cancer. And just to highlight, now in working through the China study, we talk about a whole range of illnesses and conditions. And this really here on this slide is just a partial list of a variety of different conditions, ranging from inflammatory, autoimmune, diseases of aging, different organs. I mean, I tell people that literally you are what you ate. You are right now sitting there what you previously ate. Your cells in your body are what you ate. And there's no organ in your body that's not touched by nutrition in one way or another. I'm not saying that nutrition or plant-based nutrition cures or prevents 100% of all bad things. Don't mistake my meaning. But clearly nutrition has a very broad, very, very, very broad effect on really every organ and touches many different disease processes. This is only a partial list on this slide. So 4 years, very in-depth education, full-time, writing, reading, discussing, and here I had fully on this, back to this analogy, I fully now was on this sort of China study plateau here in Ithaca, New York. I was very impassioned by the information, by the idea, and realized, of course, that this is much more than the charts, than the data, than the science. This is really about personal wellness. And since the China study was published over 10 years ago, we've had many, 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 many people talk to us about really their health that has been absolutely transformed, a new life, a better life, simply by changing the food that they ate. And after reading the China study, it's been wonderful. It's been very gratifying. This is just one person that actually fairly recently I've come to know, Sarah, who in her 20s had just absolutely developed a very unhealthy lifestyle, very overweight, and a variety of other medical issues kind of creeping in. And she read the China study, changed her diet, and you can see now that she has actually lost over 125 pounds by changing her diet. That's results, of course, are not typical, but she had a lot of weight to lose, and she's been very strict and really quite inspiring. And there's so many stories, not just with weight loss, obviously the before and after pictures you can see, but also patients who have had experiences and anecdotes about cancer, heart disease, health of their children, just an amazing variety of anecdotes that we've heard. And so that's really, the passion is more than just the charts. The reason the charts and the science matter for these personal stories is about living a better life and living a healthier life and getting there quickly with plant-based nutrition. So here I was on this China study plateau with this information, this passion, and I sort of now was in my late 20s and wanted to pursue this in one way or another. And I actually decided to go to medical school. So here I am, sort of leaving this bucolic China study plateau, going down to the real world, and starting medical school shortly after the publication, but very shortly after the publication of the China study. And I knew what I was getting into. I knew about the lack of nutrition education in medical school. Here I am in my first day. Not my first day, but after an early ceremony at the medical school where I attended. And this was a different anecdote. You can hear about some of the barriers separating medical education and nutrition, and I knew all that stuff. But it kind of hit me a little bit more clearly more viscerally when I was a student, and I actually saw what this means for people in their everyday life. And I just want to read very quickly something from a book, a follow-up book that I did called The China Study Solution. It's sort of the how-to companion to the China study. I want to read this anecdote because it's a visceral explanation for some of the frustrations I had. It was a day early in my training when I met a patient who taught me this lesson regarding the consequences of our broken medical system. And details, by the way, details have been changed to maintain privacy, insignificant details. On this particular day, the resident physician overseeing me asked me to go see a woman with diabetes. The young doctor pulled me aside and told me this woman was in the later stages of her disease. She was losing a lot of protein in her urine, and within the past year, she had had bilateral BKAs, or below-the-knee amputations. She is near the end, the resident told me. I knocked on the door and walked into the room to meet an overweight, middle-aged woman sitting in a large electric wheelchair that was taking up most of the limited space in the sterile exam room. I sat down and started asking her history. When was your surgery? Have you been having any problems recently? What are you hoping to address at today's visit? Really all the routine questions I had been taught. My lasting memory of that early interaction was a sense that this woman had been irreparably altered in the most profound of ways. She would never walk again. She could never again engage with the world with the ease that I did. Going grocery shopping, going outside, getting a job, cooking, going to the bathroom, cleaning herself, all were almost infinitely more difficult for her. Somehow, asking her how she was doing seemed hollow and trite. What a preposterous notion it was that I could even begin to understand how she was doing. I stepped out of the room and spoke briefly with my supervising resident. The patient had some acute issues and she was having ongoing difficulty after having lost her legs, I explained. The resident and I went in together and I watched the resident do a nuanced, skilled history and physical exam. We delved more directly into the topic of this woman's emotional state after her surgery. How was she doing at home? How was she coping? What were her moods and how did she feel from day to day? I stood there as the patient explained that she was having a hard time, but she was exploring ways to improve her situation. This was a woman who was not giving up or backing down. She had been attending a job training program for disabled people, and as she talked, it became clear that this was no matter of dollars and cents. This went to the core of her feeling like a worthwhile human being. She was talking about proving to herself that she had something left to contribute, could be of some use in the world. But her attempts so far had largely met with failure. She had been having an exceptionally difficult time adapting to the bulky chair and really found it overwhelming to think that she could ever be employed given her physical disabilities. She had spent months in training only to be wrenched away from her aspirations time and time again, with the monumental challenges of daily life. Her struggle and her bitterness were palpable as she talked. Every one of her attempts at self-betterment involved overcoming a mountain of doubt, fear, and hopelessness. At one point, when she was talking about the relative absurdity of ever being employed, she bitterly stated, "I've thought about being a whore, but I couldn't even do that. No one would pay." Her frustration barely covered a mountain of raw sadness. When she suggested she would be useless even as a whore, an awkward silence fell across the room. The bitterness, the pain, the self-loathing had been put into words. In my naivete, I let her emotions overwhelm me, though I was able to hide it. The resident told the patient she shouldn't say things like that about herself, but it was a limp response. "Am I making you uncomfortable, doctor?" the patient said. Of course she was, but it didn't need to be said. We stepped out of the room and grabbed the attending physician, a kind, generous woman who worked tirelessly and selflessly for the underserved. She was toward the end of her career with a sizable belly herself, and she politely listened as we presented the patient, and then all three of us went back to talk to the patient. By that time, the woman had regained her sense of calm and confidence. The attending broached the topic of things she should do to improve her situation, and the patient had a few more questions about that. And then she brought up a topic that comes up all the time. "What should I be eating, doctor? I'm really trying everything I can to lose weight, but it doesn't seem to be helping." The patient told her to watch out for sugars, to avoid bagels, to use low-fat dairy products, that fat-free milk and reduced-fat cream cheese were in fact very tasty once you got used to them. She did this with considerable enthusiasm and compassion, perhaps hoping that helping her focus on avoiding bagels might take her mind off the inevitable progression of her advanced disease. I cringed inside. Coming off a 4-year project co-authoring the China study, having spent countless hours reviewing nutrition literature, I knew a major opportunity had just been missed. I have never forgotten that patient, perhaps because it was one of the first moments when I felt in a visceral way how poorly the medical system can function. Here was a woman who had a problem caused by the simple choices she made every day, but she still seemed unclear about why she was sick or how her choices were impacting her health. At some point years earlier, she had developed diabetes and started visiting doctors. She undoubtedly interacted with compassionate, intelligent physicians like the attending one that day, who had provided her with the latest diabetes care, including pills and insulin, and yet her disease had progressed. She had moved on to a variety of specialists and a surgical team so skilled that they could cut off both legs and not have a single complication result, and yet her disease progressed. She had reaped the rewards of the technological advances that devised an electric wheelchair that would have been unfathomable 50 years ago, and yet her disease progressed. Through all of this, she still was unclear about the dietary advice that could save her life, her legs, her eyes, her kidneys. She had been in the medical system for years, and yet her preventable, perhaps even curable disease had progressed. As I sat in the tiny, crowded room looking at the stumps just below her knees, bathed in the awkwardness of an inexperienced trainee, I felt to my core the tragedy of this woman who is still asking what she should still be eating. The medical system, dozens of compassionate, intelligent, skilled doctors, nurses, and other professionals she had known had profoundly failed her. We had failed her. She sat there with us that day, revealing her raw emotions, her bitterness and lack of self-worth, her pain and difficulty, her disability, and it didn't have to be this way. She was at the end, desperately struggling to improve the future against all odds, and it didn't have to be this way. If she had changed the food she ate every day years before, this whole process could have been averted. What she was eating, what you eat, what I eat, has a profound effect on our health. It is more powerful than anything your doctor can give you or do to you. So, this story actually is so commonplace in medicine that, very, very quickly it becomes, just another a moment, just another interaction. This is basically the standard kind of experience in chronic disease care in the medical system, and it was really just the first time you see it, it's just kind of overwhelming. But this is a testimony to the current state of medicine, unfortunately, and some of the damage caused by this canyon between nutrition and medicine. After medical school, I went to the University of Rochester Family Medicine Residency Program, and I spent 3 years in that program, countless hours in this particular hospital. I remember, some ungodly amount of work and hours. This is a view of downtown Rochester from one of the stairwells at that hospital. More meaningful to me, I'm sure, than all of you, just recalling and remembering the amount of work to go into, taking care of the team and writing notes and stuff before the sunrise here in this picture, here in downtown Rochester. And I graduated from residency, and now in this analogy, I'm sort of, onto the real world here at the hospital in this plateau on the other side of this canyon, and a full attending board-certified family physician. And this is where I practiced up until very recently in a very standard family medicine office. This is outpatient primary care. If you go in there, you might see me when I was practicing in a very standard exam room, and I was working with people who generally were not coming to me for nutrition counseling. This was people came because they needed a primary care doctor, they needed refills, they had belly pain, they have chronic disease, and so forth and so on. And what certainly was, kind of a rough crowd in some ways. My patients' insurance, 31% were on Medicaid, 12% on Medicare, 28% had no insurance at all, and 29% were privately insured. So less than a third with the private insurance that all of us sort of covet. It was an amazing learning experience. Now that I having written the China study, that knowledge and experience behind me throughout medical school and residency, I continued to educate, publish, and write about nutrition as I could when I had time. Now putting into practice within the standard medical system, I certainly had a first row seat to some of the barriers and difficulties in counseling people on plant-based nutrition. And I just want to briefly mention a few things. And to set the stage for that, let me briefly discuss the stages of change. Because one of the things I found, and I'm sure many of you who have sort of come to believe in this way of eating, it's surprising how difficult it is to get people to change. And even as their doctor, even as their primary care doctor, I could sit there and I could say, you can get off your medications, reverse these illnesses, and sort of start to get out of the medical system just by changing your diet, lifestyle, exercise. Would you be interested in doing that? And I can say honestly that most people are not interested in that, was my experience. A minority are. Maybe some people will take a long time to kind of let it circle in the back of their head, but most people were not interested. So why is that? Why is this such a hard thing to get across? And Stages of Change model was developed with regard to tobacco, and it's widely known because of tobacco, but it's really a behavior change idea. You can be in pre-contemplation. Let's go with tobacco for an example. Pre-contemplation, you have no interest in quitting smoking. You're currently smoking, but you have no interest. Contemplation is really when you have some vague sense that over the next 6 months, perhaps, you want to quit, but you don't really have a plan in place. You haven't set a quit date. You haven't mustered your resources. That's really preparation. Preparation is, okay, you're going to quit. You're going to change something within the next 30 days. You've mustered your resources. You've gotten your plan in place, your action plan in place. You've started telling people, this type of thing. You're really getting serious now. And then finally, there's an action stage where you've done it. You've quit smoking or changed whatever. And now you're really working at it. But you have to keep working at it for a while until you're sort of smooth sailing into maintenance phase. And that might be 6 months or so, depending on what you're working on, what you're doing. And realize, of course, that at any point, at any of these stages. You can kind of recur, relapse, and go back, forward. This is not a linear model. It's necessarily, you can kind of go through any of these stages. And so this also applies, I think, to dietary change as well. And the reason I mention all of these things, to give you some background, is that there are some interesting surveys done in the 90s of U.S. smokers, various sites around the country, and they gave them a survey of people who smoked to figure out which stage of change they were in. It turns out 40% of smokers in the U.S. were in pre-contemplation, 40% were contemplating quitting smoking in sometime in the next 6 months. Preparation, about 20% were actually about to do it in the next 30 days. They had a plan in place, they were going to do it. And it's kind of remarkable that across these various survey sites, these numbers were actually astonishingly consistent across the various survey sites. So they did the similar surveys, very similar methodology and so forth in Europe across different survey sites in Europe. And this is very interesting. Across Europe, smokers in Europe, what they found in Europe was that 72% were pre-contemplation. So they had no interest in quitting smoking. 20% were going to quit sometime vaguely in the next 6 months. Only 8% had an action plan. So this whole thing in Europe, using similar methodologies, surveys, so forth, the whole population in Europe seemed to be shifted to a stage is less favorable to behavior change. Whereas all this consistency across the U.S., Europe had the different. So naturally you ask, why the heck is that? What is associated with people having no plan to quit smoking in the next 6 months? Of course, they asked that because of this, there's a natural question. And what they found, the strongest correlation between the percent of people who are pre-contemplative, the percent of people having no interest in quitting, the strongest correlation was with smoking prevalence. Now, this is a correlation. You can't imply causation. This could go in different directions. But there's an interesting idea underneath this graph that I want to share. And this idea, this possibility, is that the higher the smoking prevalence, the more people around you or the more people in the community smoking, the fewer the people who are interested in quitting. There's sort of maybe a possibility from this, an insinuation that social norms, what you see that's normal in your society or the people around you, is actually dictating what you're thinking about doing with your own behavior. Okay, now that's a very interesting thought. Intuitively, it's almost kind of common sense and makes and obvious, but it's a powerful idea. And let me add to that. So if that's true, if social norms are true, and the patients I was seeing, and I was kind of scratching my head, they had just absolutely no interest in nutrition. I had to draw back and ask myself, what is the prevalence of a whole food plant-based diet? Not even vegan or vegetarian, but a whole food plant-based diet among people eating the standard American diet and sick from it. It is, what is the population? 95%? That's probably being generous. It's probably 99%, right? 99% of the population walking around in the country are actually thinking about changing their diet to a whole food, 95% are not thinking at all about changing their diet to a plant-based diet. Maybe a couple percent have heard something about a whole food plant-based diet and they're actually thinking about it, thinking about changing sometime in the next half a year, taking steps, and maybe 1-2% are actually implementing more of a plant-based diet. So realize that social norms are absolutely stacked against my patients in profound ways. And there's some very interesting evidence that supports this idea, this notion that social norms are so important. This was data from the Framingham Heart Study, actually, and they put some social questions on their questionnaire. And they looked at the whole network of people and social networks, and they found some very interesting relationships. Let's start with Rupert here in this slide. Rupert goes to church. He has a good friend, Bill. They see each other over donuts, every weekend. And they're quite close. I mean, they both sort of check off the boxes. They're both friends. And it turns out that if Rupert is obese, and you just look at the health conditions of both Bill and Rupert, if Rupert's obese, it turns out that Bill has a 45% increased risk of obesity, above the statistical likelihood based on just general population. 45% increased risk of being obese himself. This is interesting in that it's not just, there's some interesting nuance here. Location doesn't matter. So Bill and Rupert could live on opposite sides of town, and they would still have this relationship, this still increased risk. The directionality of the friendship does matter. So let's say Bill does not really like Rupert. Rupert always hangs around Bill, and Rupert thinks they're good friends, but Bill is sort of smiles and nods and wants to get away from Rupert as quickly as possible. This relationship is the odds of obesity being common to both Bill and Rupert are much stronger if they both like each other. Okay, so the directionality of the friendship matters quite a bit. And it turns out that men seem to have more influence over other men. Women seem to have more influence over other women. Let's not stop there, though. Bill has a friend from college, an old college friend named Mary, and they are still actually very good friends. They see each other frequently, but Mary lives a few counties over, and they see each other a couple times a month at most. But they're very good friends. Now, Mary doesn't know Rupert, but it turns out that if Rupert is obese, Mary has a 20% increased likelihood of being obese herself. All right, so there's 2 degrees of separation. Now, Mary is a consultant. She works around the country, and she travels all the time with her work partner, John. John actually lives 5 states away, but they're very good friends. And John, of course, has no idea that Rupert exists on the planet. But it turns out that if Rupert is obese, statistically in these social networks, John has a 10% increased risk of obesity. Now, it's not just obesity, it's also things like insomnia, inadequate sleep. It's also marijuana use, it's cigarette smoking, it's depression and loneliness. And when you look at our population in general, if it's true that these health conditions are so strongly spread somehow among social networks or related to our social connections and social norms, where are we and how difficult is it as a society when 70% of Americans are overweight or obese and 75% of adults aged 55 to 64, these I consider to be young adults. As a primary care physician, these are people often still working full-time, saving for a retirement they hope is long and robust. And among this population of adults, 75% are on a prescription medication. 20% of this age range of adults are on 5 or more prescription medications. And this is an age range where these Iron Men that, what I grew up, this sort of studs of Iron Men, Kevin Costner and Bruce Willis, are now in. And, as a population, we are unhealthy and medicated. So if social norms and social relationships sort of dictate how we think about health and how we behave, clearly this is a big deal. This is a big deal. And this actually, in my mind, is the number one reason I had a hard time with so many people trying to get them to change their diet and lifestyles in a traditional medical setting. This is the number one thing. No one else they knew did it. It was a new idea. And realize that all of us, you, me, everybody, whether you're good at dietary change, bad at diet, whatever, all of us, our behaviors are more strongly dictated by our social circumstances, both in the past and current social circumstances. Our behaviors are more dictated by those than many of us consciously realize. Okay, that's a very profound influence on what we do, and it's very profound on the people who you try to convince and won't change their diet. Your friends, your coworkers, your family. If you've had these conversations, you know how difficult it is. And this is a big deal. Now, it's not just social. Okay, it's also biochemistry. We have an environment that's pushing toxic foods that have many addictive qualities. And the 2 substances that have been most studied and most clearly have addictive substances are sugar and fat. Okay, sugar and fat. People know about sugar, not so many people know about fat, but there's biochemistry here that's compelling. Both of these stimulate dopamine pathways like other drugs of abuse. If you look at animal research, animals will increase their intake over time, given limited access. So animals will binge. There's binging behavior easily demonstrated across these things. Another sort of core feature of addictive qualities, addictive substances. There's also reward tolerance to a high-fat diet. What do I mean by that? With a chronic high-fat diet, the reward becomes less rewarding. So the more people consume sugar, the more people consume fat, the more they get used to it after a while, and it becomes less of a reward. The brain dials it back, and this is very similar, overlapping ideas, of course, with what you may have heard from Dr. Doug Lisle in The Pleasure Trap. And then also a characteristic of addiction is that after being given a high-fat diet or a high-sugar diet and then being forced to abstain, you take away the sugar or fat. Animals exhibit anxiety, stress, and craving very clearly through a variety of different measures. So there's actually physical withdrawal symptoms from these substances. So we have a social environment that's stacked against us, profoundly stacked against us, and we have actually biochemistry that's also driving our cravings, driving our interests and desires, and our tastes. That's much more powerful than people realize. And so you have stores like this, and this is not an ill-conceived store. This is quite a good store. You have everything addictive here. You have candy, tobacco. You have here you see candy, chips, soda, tobacco, cigarettes, and you need your money to get them right away. So you got an ATM and phone cards, which is perhaps the one thing here not addictive, but I'm sure some people who like to speak on the phone, but I doubt that you could say they're addicted. But this is a good picture here of where we are. We are having our biochemistry pushed by addictive qualities, and we're in a social network that make it very, very difficult to think about change. So these are profound barriers to bringing nutrition into medical care. All right. The other thing is insurance reimbursement. This is a more profound barrier to nutrition and medicine. This is just one example. Medicine pays for pills, procedures, and diagnostic workups that are high tech and high intervention. And for example, look at this price here. This total hospital and physician cost for coronary artery bypass graft, so bypass operation, for an uninsured patient in 2015. Now, they did a survey for people and said, if I had no insurance, went to your hospital, what would it cost for an episode of care that includes a bypass graft, and all the doctor's fees, all the operating room expenses, all the materials, so forth and so on. How much do you think this costs? Just think in your head. I want you to think in your head how much this costs. Make a guess. It turns out the answer is $151,000 for this one episode of care. And the range across different hospitals ranges tenfold, from $44,000 to almost $500,000 for this one episode. The media has paid a lot of attention to the differences in cost of medical care across different locations. And very interestingly, this cost really has no relationship to the quality of outcomes or quality of care that people receive. I mean, whether you spend $75,000 or $375,000, there's not really good data that shows that the high cost places actually produce any better outcomes. Okay, so media has focused a lot on this disparity of cost, which is ridiculous. I agree. But no one is sitting back and saying, wait a minute. Here we have heart disease and all this data about plant-based diet, reversal of heart disease, and the unnecessary, the unnecessary need for elective, the keyword elective bypass operations, not if you're dying with a heart attack, but elective bypass operations. Why are we spending so much on this thing? why the heck are any of these numbers acceptable for a disease that's so related to diet and lifestyle? No one's really asking that, unfortunately. But back to the cost thing. So insurances will pay astronomical fees for these intensive, dangerous procedures. These are not the numbers insurances pay, but insurances will pay astronomical fees. We have, and if you look at the value in the medical system, the whole value of what's valued in our medical system, specialists, which are often proceduralists, do procedures, their average pay is twice as high as a primary care doctor who sort of sits back and manages medications and does the initial diagnostic workup for many things. So clearly we have an emphasis on procedures and proceduralists in our medical system. Just to compare these numbers, we have a group class, a lifestyle intensive class at the University of Rochester Program for Nutrition and Medicine, which I'll touch on in a little bit. The number of people who could take our 8-week class for the cost of one bypass operation. Now, our 8-week class is very intense. It's about 32 hours of small group education with me, my wife, also a physician, chefs and so forth, 16 catered meals, cooking classes at the New York Wine and Culinary Center, beautiful teaching kitchen, a shopping tour, book, resources, and all this stuff, individual consults for everybody. The number of people who could take that for one bypass is 138 people. 138 people. Insurance will only pay for one of these two options, and that is the bypass. So this is a real big barrier to people who are trying, even nonprofit hospitals. They have to balance their budget. They can't just hemorrhage money year after year. No organization is going to do that. And when you think about creating structures that are financially viable, the fact that there's disparity and reimbursement exists makes it very, very difficult to have comprehensive behavior change programs thrive in a traditional medical setting. So in the current paradigm, where we are now and where I've been, intimately familiar with both sides of this canyon here, most people on this side of the canyon here in the medical system don't even know that there's another plateau. They have no idea that diet and lifestyle matter so much and that plant-based nutrition has so much evidence behind it. They have no idea. So there's no canyon. It's just sort of high up on the hill, high up on the plateau is the medical system where people are good people. And let me say, the doctors I have worked with and trained with have been some of the most kind, hardworking, intelligent, compassionate people I've ever known in my life. Okay, this is not a knock against practitioners in any way, but the medical system as we know it it's such a strong paradigm. We have such strong barriers around our established thought that we don't even know that there's another option. So what we need to do in medicine is build a bridge really between plant-based nutrition and the power of plant-based nutrition and the standard medical system, and really use the best of both worlds and learn about what the best of both worlds is, what that is, and how to use both aspects. And that's actually what we've been doing at the University of Rochester. So I'm a instructor of clinical family medicine at the School of Medicine and Dentistry at the University of Rochester. But more importantly, recently I'm also have co-founded with my wife, Dr. Colin Campbell, and I'm the clinical director of a very small program, the Program for Nutrition and Medicine. And this is within an academic medical center. We're supported within primary care. It's a very unique sort of special opportunity. I see people individually for consultations, and I do diet and lifestyle intensive consultations. We have this 8-week group program, and we do a variety of other group programs and immersions. Similar to PlantPure, we do jump starts, and we also have a 1-week immersion where people from around the country and actually Caribbean out of the country have come, and that's a wonderful thing. We do community seminars for like $15 a pop. People come, they pay for a lunch. We have a catered meal at all of our events, and we have some education and information. We also are getting into medical education and research as well. So consultation, this is just the office visit to talk about diet and lifestyle. And it's not 15 minutes. Another barrier, is lack of time. It's not 15 minutes, it's at least an hour for this. Our lifestyle intensive is a small group program. This is a back of actually, I think it's one of the largest YMCAs in the country. It's just built within the past 10 years or so. It's absolutely phenomenally beautiful YMCA. And there's a primary care office that the University of Rochester has built onto this that we work out of through these doors. In our small group programs, we do work with the New York Wine and Culinary Center. Like I mentioned, we go down and people actually get in the teaching kitchen and learn how to cook this whole food plant-based diet. And it's very, very gratifying. This is our community outreach lunch with docs. People can come pay for the lunch and get some education. And it's a nice community as well. People who come back month after month. Get to know each other a little bit, and it's sort of that social aspect that's lacking in our society. So we do that, and then we also have this immersion. I'm just very briefly give you some details because some of you might be interested. It's July 23rd in 2017 is our next one. It's 7 days, 7 nights, medically supervised. I see everybody individually, go over medications, history, individual recommendations, and so forth. It's a beautiful Woodcliff resort. And we do excursions into the Finger Lakes. This is a Woodcliff Hotel and Spa. Very fancy, very beautiful. Catered buffet meals 3 times a day, all you can eat. And working again with the New York Wine and Culinary Center, actually cooking in their teaching kitchen and getting some chef demonstrations. It was really wonderful, really fantastic. And our first group came in very, very healthy. Actually, more than average normal healthy weights, lower than average cholesterols, but we still saw blood pressures drop and weight come down with people eating all they could 3 times a day for 7 days. And it's just one of the most wonderful experiences as a physician to see people sort of light up and get how powerful this can be. I want to share with you and let me know if this isn't working. I want to share with you our video about how we're trying to bridge this canyon here at the University of Rochester.
It's really quite amazing what we ask our patients to do as physicians. We ask patients in our system to trust us with major surgery. We ask patients to take medications for their illness that may have various serious side effects. Here at the Program for Nutrition and Medicine, we want to add a new dimension to treatment, and that is treating the cause of so many of our chronic illnesses, diet and lifestyle.
Here at the University of Rochester Program for Nutrition and Medicine, we want to help you live your healthiest possible life. To do this, we have consultations. You can come in and see us for an office visit, or you can come to one of our more intensive programs, including our 8-week class and our immersion program. If you want to learn a little bit more about living a healthy lifestyle, as well as our programs, you can come to one of our community outreach events, during which we have lecture and discussion of a nutrition or lifestyle topic, as well as a delicious plant-based meal.
So I started the Lifestyle Intensive program because I have suffered for the last few years of multiple symptoms that really weren't diagnosed with anything except celiac disease and asthma. I decided to do this because I was desperate to make myself feel better. I felt like we were immediately empowered to learn how to take charge for ourselves. It was about looking, is this really wholesome? Is this something I should put into my mouth and help heal my body?
One of our most powerful tools is a healthy diet. We believe that a healthy diet is a plant-based diet. Plant-based diet consists of a rich variety of fruits, vegetables, whole grains, beans, and other legumes, as well as healthy starches such as sweet potatoes. The next question you might have is, what does a plant-based meal look like? And a plant-based meal can be sweet potato enchiladas, it can be mushroom and spinach lasagna, it can be a pineapple stir fry. And at our programs, we want to help you make these meals easy and tasty and familiar to really help you enjoy this food.
Well, I started a plant-based whole foods diet 2 years ago after becoming a patient at Dr. Campbell's. When I started Dr. Campbell's plan, I had weighed in at 242 pounds. Presently I'm down to 187 pounds, which is about a 55-pound drop. My pant size has gone from a 38 waist down to a 34. I no longer need to take the daily statin, daily aspirin, or one of the blood pressure medications I'd been prescribed. Before I started even before I started statins, my cholesterol was up to 230. Now with just the plant-based whole foods diet alone, my cholesterol is 130 to 140. And I'm looking better, I think, and feeling better than I have in the past 15 years.
So for weight loss, I am down about 35 pounds in 3 months. With that, I have found I'm sleeping much better. My asthma, I just returned to my doctor, and she said to me, I'm the healthiest I have been in several years that she has seen. I actually feel healthy for a change.
We recognize that participating in these programs is a big investment for our patients. And really our goal at the Program for Nutrition and Medicine is to make this investment absolutely the most efficient use of your resources as possible. So really at the end of the day, you have the best outcomes that you possibly can, not just in 2 months, 3 months, but for the rest of your life.
And I hope that I won't have to go through the same things my father, my grandfather, my uncles went through, as far as angioplasties, quadruple bypasses, ablation surgery, pacemakers. I believe that this is probably the best chance I have of avoiding all that.
This has been life-changing for me. I feel like I am empowered. This has definitely confirmed I'm healthy and I'm on my way to being even more healthy.
So I talked a lot about some of the challenges and difficulties, but I can tell you that I don't think 10 years ago we could have started that program, gotten the okay to start a program like that at a major academic medical center under the brand of a major academic medical center. And I'm very excited about where we are going, and not just us, but I think there's a lot of reasons for optimism and hope. The USDA Scientific Report 2015, Dietary Guidelines Advisory Committee, you look at their executive summary, and all over that executive summary are the terms plant-based, and really suggesting plant-based diets were better for the environment and better for human health. And Kaiser Permanente, of course, one of the largest medical organizations in the world, in the country for sure, put out a paper in their journal recommending that their physicians suggest a plant-based diet for all their patients. The U.S. Preventive Services Task Force, a major body that determines guidelines that many primary care doctors follow for screening and prevention, that type of thing, put out a statement a couple years ago now that said all people who are overweight or obese with any heart disease risk factors, high blood pressure, high sugar, high cholesterol, any of those people should be referred to intensive behavioral intervention programs. All right, that's like 75% of them. I feel like that's some huge number of the patients in our medical system. And they're saying all of them should get intensive behavioral intervention. American Institute for Cancer Research, even the cancer organizations are starting to use the term plant-based. American Cancer Society, traditionally more conservative. Even you look on their website, at least when I did, I saw some promotion and some idea of this concept of plant-based, more plants. I'm not under the illusion that all of these people are recommending the very strict whole food plant-based diet that I do. But these are big changes. These are big organizations moving in this direction. And you'll hear from Dr. Williams in this PlantPure Summit, president of the American College of Cardiology, coming out and saying, plant-based diet for all of his patients, a whole food plant-based diet for all of his patients. Popular entertainers, this is Beyonce, James Cameron, the famous director, even Arnold Schwarzenegger, the Terminator himself, has come out saying less meat more recently for both the environment and human health. And you can go to Cleveland Clinic Wellness Institute and see Dr. Esselstyn there for heart disease. You can go to Montefiore and see Dr. Rob Asfeld at the Cardiac Prevention Wellness Program. There, you can go to Bellevue Hospital, Dr. Michelle McMacken, in the weight management, and learn about plant-based diets. And you can go to, they're sprouting up everywhere, the Barnard Medical Clinic in Washington. PlantPure Nation is doing some cutting-edge stuff in Florida and in Texas with large hospital systems in those places, hopping on board as well. And of course, you can come to the University of Rochester Medical Center here in upstate New York, where I'm very proud of the comprehensive services that we have offered here. I think the world is a changing place. So these things would not have happened 10 years ago when we first published the China study. No way would these things have happened 10 years ago. So there's change. I think there's change, and I think there's a lot of reasons to be optimistic. One final plug here that I want to make, and this is important for everyone around the country who can't travel and pay for fancy wellness vacations and that type of thing. The T. Colin Campbell Center for Nutrition Studies, I'm the medical director there. This is our website. We have a certificate program that's very popular in partnership with eCornell. And we just recently came out with an updated certificate program that we're very excited about, that people can take, from the convenience of their own home, wherever they are. So check that out. That's another way that we're trying to bridge the canyon between medical practice and medical thought and paradigms and plant-based nutrition. This is the University of Rochester website. And, thanks for sitting through all that. I hope you enjoyed it, and take care.